Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Obesity, Aspirin, and Risk of Colorectal Cancer in Carriers of Hereditary Colorectal Cancer, a prospective investigation in the CAP2 study by Mohammad Movahedi et al. My name is Jeffrey Meyerhart, and I am the Clinical Director of the Gastrointestinal Cancer Center at the Dana-Farber Cancer Institute and an Associate Professor of Medicine at Harvard Medical School, both in Boston, Massachusetts. Colorectal cancer is the fourth most common cancer diagnosed in the United States, with approximately 132,000 cases diagnosed annually. It is the second most common cancer globally, with an estimated 1.4 million new cases each year. 50,000 people die of colorectal cancer in the United States and nearly 700,000 across the globe each year. Defining risk factors for the development of colorectal cancer has been the subject of numerous research efforts. While these risk factors can be divided into multiple different groups, one broad characterization would be hereditary, related to the presence of other diseases, including Crohn's disease, ulcerative colitis, and diabetes, and modifiable risk factors. Up to 20% of patients have a potential hereditary etiology, which can be broadly defined into those with histories consistent with an inherited syndrome versus those without a clear known syndrome but having first and or second degree relatives with a history of colorectal cancer or colorectal adenomas. Lynch syndrome is the most common cause of inherited colorectal cancer, accounting for 3% of the newly diagnosed colorectal cancers. It is characterized by a significantly increased risk for colorectal cancer and endometrial cancer, as well as the risk of several other malignancies, including cancer of the ovary, stomach, small bowel, hepatobiliary system, transitional cell carcinoma of the renal pelvis and ureter, glioma, and sebaceous neoplasms. Lynch syndrome refers to patients and families with a germline mutation in one of the DNA mismatch repair genes, MLH1, MSH2, MSH6, PMS2, or the EpCAM gene. It is an autosomal dominant disorder. The role of the DNA mismatch repair system is to maintain genomic integrity by correcting base substitution mismatches and small insertion deletion mismatches, which are generated by errors in base pairing during DNA replication. Inactivation of both alleles of one of the mismatch repair gene leads to defective mismatch repair. As a general rule, patients with Lynch syndrome have a germline mutation in one allele of a mismatch repair gene, and the second allele is inactivated by mutation, loss of heterozygosity, or epigenetic silencing by promoter hypermethylation. In terms of modifiable risk factors, numerous prospective studies have led to some consistent observation of exposures that increase risk of colorectal cancer. While such epidemiological data often lead to inconsistent results in many disease types, lack of physical activity, increased adiposity, and higher consumption of red and processed meat have been shown in numerous reports to increase the risk of developing colorectal cancer. The World Cancer Research Fund and the American Institute of Cancer Research list these exposures as having convincing evidence of increased risk of developing colorectal cancer. In addition to modifiable risk factors of dietary and lifestyle exposures, chemoprevention has been an area of rigorous research to prevent colorectal adenomas and cancer for the past 2 decades. The agents with the most research, including multiple randomized clinical trials as well as supportive prospective observational data, are aspirin and nonsteroidal anti-inflammatory drugs. These agents reduce the risk of polyps and colorectal cancer in primary prevention, as well as reduce polyps in secondary prevention, specifically patients with prior polyps and or colorectal cancer. A key question of all these data on risk factors is how they interact with each other. If you have a family history of cancer, should one focus on weight control? Should you take an aspirin daily? Many scenarios can be created, and all combinations are nearly impossible to test in a rigorous manner with sufficient power. Nonetheless, studies directed to specific populations may prove to be more fruitful to target focused behavioral change intervention. The Colorectal Adenoma Carcinoma Prevention Program, known as CAP, was launched in 1990, and 2 studies were developed. CAP-1 studied 200 young people with familial adenomatous polyposis, a familial syndrome associated with mutations in the adenomatous polyposis coli gene, APC. CAP-2 focused on 1,000 people with Lynch syndrome, most carrying pathological DNA mismatch repair gene variants, plus previously affected patients within families meeting Amsterdam criteria for hereditary non-polyposis colon cancer. CAP-2 used a factorial 2x2 design to assess 2 agents, aspirin at 600 milligrams daily and resistant starch. In total, 1,071 subjects from 43 international centers were enrolled. The primary outcome was detection of at least one adenoma or colorectal carcinoma at follow-up. The initial report of this trial appeared in the New England Journal of Medicine in 2008 after an average duration in the study of 29 months. The investigators concluded that, quote, the use of aspirin, resistant starch, or both for up to 4 years has no effect on the incidence of colorectal adenoma or carcinoma among carriers of the Lynch syndrome. However, long-term follow-up reports for each intervention have been published with 52 and 55 months of follow-up. In the Lancet Oncology in 2012, the investigators reported intent-to-treat analysis that resistant starch provided no protective benefit towards development of colorectal cancer or adenomas. In contrast, in the Lancet in 2001, investigators reported on the aspirin intervention. By the intent-to-treat analysis, the time to first colorectal cancer showed a hazard ratio of 0.63, but the 95% confidence interval crossed 1 at 0.35 to 1.13, and thus the p-value was not significant at 0.12. For participants completing 2 years of intervention, approximately 250 in each arm, pre-specified analysis yielded a hazard ratio of 0.41 with a 95% confidence interval of 0.19 to 0.86 and a p-value equal to 0.02. While these results were technically not positive as the primary intent to treat analysis did not reach statistical significance, the data support consideration of aspirin in the context of individualized risk-benefit assessments for Lynch syndrome patients. The other power of a randomized clinical trial of the size of CAP-2 is the ability to perform secondary analyses to understand more about biology and physiology of the population studied. The CAP-2 investigators leveraged the cohort to try to study the intersection of familial risk of colorectal cancer, modifiable risk of colorectal cancer, and chemoprevention against colorectal cancer. In this article that accompanies this podcast, Movahedi and colleagues report on the association of adiposity and risk of colorectal adenomas and colorectal cancers in CAP-2 Lynch syndrome patients, as well as the impact of the aspirin intervention based on degree of adiposity. They used the long-term follow-up data with a mean follow-up time of 55.7 months. Adiposity as an exposure was considered in 2 ways. First, they created 3 categories corresponding to the World Health Organization criteria combining under and normal weight individuals defined as a BMI less than 25 kilograms per meter squared, overweight defined as 25 to 29.9 kilograms per meter squared, and obese defined as a BMI greater than or equal to 30 milligrams per meter squared. Second, they defined BMI as a continuous variable with a hazard ratio per kilograms per meter squared. There was no significant associations by BMI category or as a continuous variable in colorectal cancer adenoma. However, the adjusted hazard ratio for obese was associated with a non-significant increased risk, hazard ratio 1.28 with a confidence interval of 0.77 to 2.12. In contrast, colorectal cancer incidence was significantly associated with BMI. Obese Lynch syndrome patients had a hazard ratio of 2.34 with a 95% confidence interval of 1.17 to 4.67 compared to Lynch syndrome patients with a BMI less than 25 milligrams per meter squared. For each unit BMI, there was a 7% increased risk of colorectal cancer. While not statistically significant in either gender subgroup due to limited power, the association appeared consistent for males and females. The investigators also report significant association with increased risk of all Lynch-related cancers with increasing adiposity. Analysis of other Lynch-related cancers excluded colorectal cancer was not significant. Analysis by mismatch repair gene demonstrated considerably stronger associations with MLH1, hazard ratio 3.72 with 95% confidence interval of 1.41 to 9.81, than with MSH2, hazard ratio 1.59 with a 95% confidence interval of 0.47 to 5.44. This observation has been noted in other observation studies of MLH1 mutation carriers, but not MSH2, MSH6, or BMS2 carriers. The mechanistic basis for the apparently greater susceptibility of MLH1 mutation carriers to the adverse effects of adiposity is not known. The association of obesity with colorectal cancer in Lynch syndrome patients is an observation. More important to patients with Lynch syndrome is not an observation, but an intervention that they can do to reduce their risk of cancer. These data cannot address whether avoidance of obesity or weight loss will reduce the risk of developing colorectal cancer. However, as this cohort was derived from an intervention study, one can explore whether the intervention within the trial, aspirin and resistant starch, can alter the association of obesity with colorectal cancer in Lynch syndrome patients. A note of caution is the power of a randomized trial is lost when doing such analyses, particularly if the exposure, in this case adiposity, was not a stratification factor since balancing of treatment arms was for measured and unmeasured confounders is not guaranteed. Nonetheless, such analysis can be hypothesis generating. In the case of the Movahedi study, only the effect of aspirin is reported. Indeed, the association between obesity and colorectal cancer development was attenuated in patients randomized to aspirin. Obese Lynch syndrome subjects randomized to placebo had a hazard ratio of colorectal cancer development of 2.75 with a 95% confidence interval of 1.12 to 6.75 with a p-value of 0.03, while those randomized to aspirin has a hazard ratio of 2.0 with a 95% confidence interval of 0.61 to 6.70. The investigators report a significant interaction of 0.01. Arguably, these data are suggestive but not definitive of an intervention that may alter the risk of colorectal cancer in obese Lynch syndrome patients. The readers of this paper should be careful not to conclude that this translates to aspirin only being effective in obese Lynch syndrome patients. The authors do not provide data by BMI category for aspirin versus a placebo effect. So, how does one use this study from the CAP2 trial in clinical practice? First, as the authors note, other observational studies of Lynch syndrome patients have reported on adiposity and colorectal adenomatous polyps or colorectal cancer development with mixed results. The lack of consistency may in part be due to differences in study design, definition of Lynch syndrome by clinically defined familial risk or known carriers of germline mutations, and timing of height and weight measurements. This current study is the largest to date with 937 Lynch syndrome patients, and even then, only 55 colorectal cancers occurred in the study period of nearly 5 years. Nonetheless, the wealth of data show increasing risk of colorectal cancer with greater adiposity in the general population. These data certainly support this observation does not exclude Lynch syndrome patients and may even be more relevant to such patients. Further, while not a trial specifically focused on obese patients with Lynch syndrome, the data certainly support that aspirin may reduce the risk of colorectal cancer in such patients. It is reasonable for clinicians who care for Lynch syndrome patients to discuss these results and recommend weight control and aspirin chemo prevention as ways to hopefully reduce their risk of colorectal cancer. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.